This case will demonstrate a double Bony Bankart bridge repair for an acute Bony Bankart fracture. This is a 44-year-old male without past medical history. He was riding a BMX bike on jumps and fell directly on his left shoulder. He sustained a left shoulder dislocation, which self-reduced. He then sustained a second dislocation the next day, which was reduced by a local orthopedic surgeon. Patient presented to our clinic with continued pain and instability. Examination demonstrated anterior apprehension. He was neurovascularly intact. Preoperative imaging demonstrated Bony Bankart lesion and anterior labral tear. The glenoid fracture site is prepped using shaver and tissue elevator. The labrum is invariably attached to the bone fragment. The fracture fragment is elevated so that the anterior glenoid neck can be visualized with a 70-degree scope. This allows for the percutaneous placement of the guide for the medial anchors. Percutaneous incision is made inferior and medial to the antero-inferior portal. The fracture fragment is elevated so that the anterior glenoid neck can be visualized with a 70-degree scope. This allows for the percutaneous placement of the guide for the medial anchors. A 2.4 mm suture tack is placed percutaneously through the guide into the medial, non-articular aspect of the intact glenoid at the superior portion of the fracture site. The fracture is then provisionally reduced, and the sutures from the anchor are effectively passed anterior to the fracture fragment and associated capsulolabral tissue using the drill guide. This is a key step which simplifies suture passage. Alternatively, a shuttling device can be used to pass the sutures around the bone fragment. Sutures are then retrieved through the skin of the anterosuperior portal outside the cannula using a tape grasper. This process is then repeated at the inferior aspect of the fracture, again placing an anchor on the medial, non-articular aspect and passing sutures around the fragment and capsulolabral tissue. Antero-inferior and anterosuperior portals are then re-established with previously placed sutures outside of the anterosuperior cannula. The labrum is then repaired inferior and superior to the fracture fragment to tether both ends. A 1.8 mm knotless fiber tack anchor is placed through the anterior-inferior portal on the lateral articular aspect of the glenoid at the inferior aspect of the fracture. The repair suture is then retrieved through the anterosuperior portal. A suture lasso is then passed through the capsulolabral tissue inferior to the fracture fragment and retrieved through the anterosuperior portal. The repair suture is then shuttled through the capsulolabral tissue. The repair suture is then shuttled through the anchor using the shuttling suture, tensioned, and cut. This restores the inferior capsulolabral tissue, reducing and tethering the fracture fragment inferiorly. The process is then repeated at the superior aspect of the fracture. A 1.8 mm knotless fiber tack anchor is placed on the articular surface of the glenoid. The repair suture is passed through the capsulolabral tissue and shuttled through the anchor to secure the capsulolabral tissue and to reduce and tether the fracture superiorly. Care is taken to avoid the previously placed sutures from the 2.4 mm suture tack anchors, which will be used for the bridging construct. In this instance, a crossing configuration will be created. One suture from each medial 2.4 mm anchor is retrieved through the anterosuperior cannula. A 2.9 mm push lock anchor is then loaded with these sutures and placed in the articular surface of the glenoid at the level of the fracture. Sutures are tensioned slightly since they can still slide and cut flush with the articular surface. The remaining suture from each medial anchor is then retrieved through the anterosuperior portal and loaded into a second 2.9 mm push lock anchor. The anchor is placed more superiorly at the fracture site. With this anchor, sutures are now tensioned securely to compress the fracture fragment and cut, creating a double row bridging repair of the Bony Bankart fragment, a double Bony Bankart bridge. In this case, an additional 1.8 mm knotless fiber tack suture anchor was placed to perform an additional capsulolabral repair superior to the Bony Bankart. This was passed in similar fashion to the previous two fiber tack anchors. Additional anchors may be used depending on the extent of the labral tearing. Final construct is evaluated and found to have restoration of the articular surface, compression of the bone fragment, and capsulolabral repair with excellent glenohumeral stability. Representative postoperative CT examination is shown. Our rehabilitation protocol is initiated immediately postoperatively.